So over the past 25 years, we've become aware of the serious impact that alcohol and tobacco use in pregnancy can have, causing a range of birth defects and lifelong disabilities. And at the same time, we've become aware of the role of the healthcare provider in assisting women to change their alcohol and tobacco use during pregnancy, using a very collaborative and respectful, tailored approach to change. And the interviews and commentary that will follow here are really about illustrating that role of the healthcare provider in supporting change with women. Well, there have been really significant barriers on the road to identifying best practice in this area in terms of discussing alcohol, tobacco, and other substance use with women during pregnancy, pre-pregnancy, and postpartum. Most importantly, I think, the biggest challenge for us has been that there's been this persistent society-wide approach to addiction and problem substance use overall. We really tended to see addiction as a moral problem rather than a health one. This is a kind of a unique health problem in terms of, talking about your substance use, because it really is the only health problem that women come to the system and actually express that they're afraid that they're going to lose custody of their children simply for asking for help on substance use issues. We've done some studies around the Canadian media discourse around mothers with substance use problems, and that's shown that mothers and pregnant women who have substance use problems are portrayed as deliberately harming their babies rather than seen as needing assistance and support to change. And furthermore, the media hasn't really identified any responsibility of the system to support women. It hasn't pointed out what treatment has been offered to her or what kinds of help she might access. So it stays there kind of as a barrier both for women in knowing what's available and also for service providers in terms of what their role might be. And furthermore, the judgmental attitudes towards mothers who find it difficult to stop in pregnancy has meant that pregnant women have been afraid to come and ask for the help that they need and deserve. And healthcare providers have expressed that while they understand that it's really important to support women in this area, they don't always feel competent or confident to discuss substance use with women. So the end result of all this is that often women's substance use during pregnancy is not recognized, or women are not really supported in the way that they might be. We used to think in the addictions field that a really confrontational approach would work, or even a very simplistic substance-oriented approach would work. We used to think, just say no. Right? If we tell you that you shouldn't use alcohol in pregnancy, well then you'll just not do it, right? And over time we've seen that those kinds of confrontational and very prescriptive and substance-oriented approaches don't actually work that well. They're not that effective. The kinds of approaches that are more effective are ones that support women to make paced and achievable change that is done in collaboration with the healthcare provider, not so much in that place of being prescriptive. The other thing we've found is that asking makes a difference. That one of the key things that mothers who do get to pregnancy outreach programs or to treatment have said to us is that a huge support, the key support for them in getting there was that a professional helped them. It doesn't matter what kind of professional. It could be a violence worker, it could be a physician, a public health nurse, an EFRI worker, anybody. But somebody along the way, someone asked them and talked to them about their substance use and really supported them in making the connections that they needed to. So the literature and the best practice that we've been able to identify in this area of talking about substance use with women is pretty straightforward, right? We need to talk to all women. We need to talk pre-pregnancy, during pregnancy, and post-pregnancy. And that really it breaks down into kind of 4 simple points of making sure that you talk about substance use, making sure that you open the conversation, making sure that you actually are able to identify the women who are ready to change and how you might support that change, that you discuss with her lots of different options around how she might change and what it looks like for her. And finally, you just keep on helping her make the connections and getting the help that she needs, not necessarily only from one health service, but the health care and social service system overall. So just helping her make those connections and keeping the conversation open, for what change she might be able to make. So the stigma associated with alcohol and tobacco use in pregnancy means that we don't know exactly the prevalence of drinking during pregnancy. But in a recent Canadian Community Health Survey, about 14% of mothers identified that they'd used alcohol during their last pregnancy. So it's important that we discuss substance use with all women of childbearing years, whether they be younger women or women in their 30s, whether they be Aboriginal or non-Aboriginal, whether they be living with a high income or low income. We need to ask all, because all are at risk of having a child affected if they use alcohol during pregnancy. And at the same time, we need to really be thinking about who are the highest risk women, young women particularly. Women who are 18 and 19, women who are 20 to 24 have reported recently in surveys that they're drinking frequently and heavily, or doing what we call binge drinking. There's a significant body of evidence now for best practice in working with women on alcohol and their substance use issues during pregnancy and beyond. So a key component to best practice is taking a woman-centered or mother-centered approach. And that involves focusing on the woman's health pre, during, and post-pregnancy in a way that really supports her intrinsic motivation to change. So this is kind of an extension from the way that we used to provide support that was very fetus-centered, or that we encouraged women to change in order that their babies would be healthy, which of course we still want. But we notice so much now in the literature that that approach has often meant that women relapsed postpartum. So the second key component of best practice that's been identified, both in the literature and from clinical wisdom as well, and from women with substance use problems, is to take a harm reduction-oriented approach. Usually all of us feel a real urgency to support women to stop completely during pregnancy. But often that's not really realistic. And in the past, often we stood in this place of saying, well, unless you're willing to talk about complete abstinence, I'm not willing to help you. And I think that what the literature is pointing out to us is that by taking a harm reduction approach is that we're really starting from where she's at. We're willing to entertain discussion of the type and the amount of change that she can make. And change not only in her substance use, but in lots of other life areas as well that might mitigate the impact of the substances. So in lots of ways, I really see harm reduction as a very pragmatic approach and a very compassionate approach. That those are the two key elements of it, that we're willing to work with you no matter what you say, no matter what your goals are, and that we really see our role as assisting you to be the best that you can be. The main point that I think is really strong in the literature that supports the harm reduction approach is very much one that identifies some of the key things that women can do that can mitigate the impact of substance use in pregnancy, like get prenatal care, eat well, getting rest, reducing use of other substances as well as alcohol. So all of those things have been shown to help mitigate the impact of alcohol use during pregnancy and benefit both mothers and fetuses in terms of their health. So the other part of harm reduction that's really critical, I think, to understand is that often it's not easy for women to come to the system and say, hello, I've got a substance use problem, that she's much more likely to enter another door to get support, whether that be a pregnancy outreach program for hot lunches, or whether it might be approaching her physician for regular prenatal care, whether it's going to a Lamaze class, whatever door she's coming in. Our most important role is to make it welcoming for her wherever she turns up, and have us all empowered, no matter where she comes in, to be able to discuss the risks of substance use and really help her reduce or stop her use of substances in pregnancy as best she can. Safety's been a particularly important aspect of harm reduction in lots of ways. It's guided us in thinking about the fact that many of the women who come for help on substance use problems may not feel safe to talk about substance use with healthcare professionals. It also helps us understand that perhaps there may have been issues of lack of safety for her in her life before this that may be related to her substance use as well, that we could be working with her on. Safety in lots of ways really needs to guide our messaging and the way that we provide support. As we've been developing messaging for women around substance use and pregnancy, we've often framed it as saying, you know, there's no safe time and there's no safe amount of alcohol that you can use in pregnancy. But we're really willing to discuss with you, even if you have used already in pregnancy, that there's still lots of things you can do to improve your health and the health of your baby regardless. And that's sort of the grounding, I think, of a harm reduction-oriented approach. Finally, I think the most important piece of harm reduction is the fact that women themselves need to be able to define what it is they feel able to do and to engage with us, and that harm reduction has been about involving people with substance use problems in defining what their care will look like. We've been lucky in lots of ways to have had thinkers and researchers looking at the whole area of motivational interviewing practice, because it's been a great contribution to our understanding of how we can do this work with women. And the motivational interviewing approach has guided us in lots of ways, most importantly, I think, in terms of our foundational way of walking with women in this process, really being collaborators with her as she makes decisions about her use and her health and the health of her baby. So we've got lots of evidence now on the benefits of using a motivational approach and supporting women in changing their substance use, and also in changing a whole range of other health issues and social concerns as well. And so that's really guiding us to using approaches that follow that motivational interviewing model that includes working in collaboration with women, that includes really supporting her hope and sense that she can change, and really coming from a place that is not at all confrontational, but much more is about respect and even empathy for what she's facing. And those elements of respect and understanding and compassion and hope sound like motherhood issues in lots of ways, and I guess that's exactly what we're saying here, that these are the core elements of the kind of work we need to do with women. So, our work really is to help service providers to feel really confident and competent that they can use a mother-centered, harm reduction-oriented, and motivational approach.